Hello, my name is Jeff Kim, and I am the Medical Director for Digital Health here at Loma Linda University Health. And it's my privilege today to present on the topic of telehealth past, present, and future. I am a family doc by training, and I've had the privilege to serve here in the Department of Family Medicine and working with the residents for the past 10 years. I have no disclosures. And I have three objectives that I'd like to go over with you today. One is to demonstrate a historical understanding of telehealth as a modality of care and how that affects current applications and issues around the continued use of telehealth. Number two is to identify the key advantages around the use of telehealth while recognizing some of the pitfalls that come from not being able to see patients in person and how to mitigate them. And number three is to describe the possible future state of healthcare delivery with telehealth and how that will or will not change how we design clinical care delivery models. So what is telehealth? Just to level set all of us here, definition from the American Telehealth Association: telehealth represents the interactive electronic exchange of information via telecommunication technologies for the purpose of diagnosis, intervention, or ongoing care management between a patient and or health providers situated remotely. So telehealth is an umbrella term that generally encompasses telemedicine, digital health, virtual care, e-health or electronic health, and m-health or mobile health. Now, some of this terminology is constantly changing. We may in fact see digital health starts supplanting telehealth as the more general term. But this is a way to sort of understand and have a framework for our discussion today. So generally with telehealth, many of you have now become experts in these different modalities, but we'll discuss, usually we're talking about four different situations. One is, of course, live or synchronous video, which is a two-way audiovisual link between a person. That is a patient, caregiver, or provider, and a care provider, otherwise known as real time. There's also store and forward or asynchronous telehealth, which is an electronic transmission of medical information to a telehealth provider, a health provider, usually a specialist. There's remote patient monitoring, which is using connected digital technologies to record, collect, and monitor personal health and medical data from individuals in one location and electronically transmitting that information securely to health providers. And then there's this emerging mobile health or m-health, which is the provision of technology-enabled healthcare services, public health information, and personal health data via mobile devices. So I'd like to pause here and talk a little bit about telehealth's adoption. And so here you see the famous Everett Rogers diffusion of innovations curve, technology adoption curve. And this was probably more applicable in looking at telehealth pre-COVID pandemic. Even here at Loma Linda, and I'll go into our journey here at Loma Linda with telehealth. But I think in terms of many technologies, we look at this curve and try to decide where is it that we feel most comfortable when we're adopting new technologies. And so, in 2016 or 17, if you were an early adopter of telehealth, you might have been considered, in that 13.5%. There's a few of us here today that may have been doing telehealth for many years, maybe working through the VA, doing telephonic monitoring, and you could really be considered sort of innovators. But I'd say many of us right now probably fall in that middle, 68% by this time, given the pandemic. We're really in the early majority. And I think this is probably, like I said, was more applicable pre-pandemic, but I think when we think about the future of telehealth and the future applications that can come from it, this is a graph that's very useful to always come back to you and decide where is it that we are and where is it that we want to be and where is it that we need to be as we consider technologies in telehealth and healthcare. And so the example I always give to the right there, or to the picture that you see is of a phone, and the larger phone is called the Dell Streak. So the Dell Streak came out circa 2010 or 2011, and I actually purchased one, and it was my first big phablet, as they were called at the time. And I remember being mocked and ridiculed incessantly by all my friends whenever I would take my phone out. They would see my Dell Streak and then say that, ask me, what is that? What are you using? They would hold up a book to the side of their face and say, look, it's Jeff using his phone. And of course, you can see it pictured right beside an iPhone 4 or 4S. In fact, phones these days are much larger than the Dell Streak. And so what we thought was sort of innovative and cutting edge back then now is commonplace. And I think this is a theme that you'll find very often. And so, my wife, at the time I was dating, and I pulled out my phone, and she'll still tell the story that she thought I was one of the strangest guys for having this huge phone back in 2011. But she did marry me. So when we think about the history of telehealth, there's a lot of things out there right now. Some groups like to go back to the development of the telegram and using electronic telegram messages to diagnose and to provide healthcare. Some people talk about Alexander Graham Bell and the innovation of the telephone. But some of the early sort of milestone places where telehealth were used, one was this relationship that Massachusetts General Hospital had with Logan International Airport and providing remote care to patients that were located in that airport. And then NASA, of course, was an early innovator in telehealth, mainly as a way to develop technology to monitor astronauts that were going into space. But they transitioned and also did a lot of work with terrestrial projects and what they refer to as terrestrial projects. And so STARPAC was an example of this. That was, STARPAC stands for the Space Technology Applied to Rural Papago Advanced Healthcare. So that was remote healthcare being provided to a remote area in Arizona, to an area there. And so NASA learned from that experience and also was involved in providing healthcare to several disaster areas in Armenia and elsewhere, and really using and developing telehealth in the terrestrial sphere that could later be passed on as they did telehealth in space. Some of you in the audience may work or have experience with using telehealth at the Veterans Administration. The VA, because of how it is sort of vertically integrated and organized, it has really effectively used telehealth for several years, mostly through chronic disease management, telephonic visits, and now with video visits. They've done a lot of good work with group visits as well. And the satisfaction rate for telehealth adoption has been quite high. They provided veterans with tablets and the ability to connect that way and to try to improve access to care at the VA. And then largely at a lot of academic institutions, a lot of the telehealth initiatives, maybe in the early 2000s, were actually grant funded. And here at Loma Linda, there was pioneering work done in the emergency department and in the obstetrics department as well, with providing maternal fetal medicine specialty care to more remote areas. And so that's sort of where a lot of the exciting work started here at Loma Linda with telehealth. So even though telehealth is very ubiquitous now with the COVID-19 pandemic, I think it's important to understand what telehealth looked like pre-COVID. And specifically, we'll be looking at CMS and their definitions for telehealth. That's sort of one of the main payers and players. So pre-COVID, telehealth really had to meet sort of 5 components in order for the Centers for Medicare and Medicaid to reimburse telehealth services. So those 5 key components were: 1, the patient would need to be seen from an originating site. Now, that originating site was defined specifically by CMS as either a clinic or a hospital, and they had an established list of sites. The second component was that the originating site would have to be in either a rural health professional shortage area, an HPSA, or in counties located outside metropolitan statistical areas. So CMS early on identified telehealth as a way to provide more specialty care to patients located in rural areas that maybe didn't have access to the specialists or the care that they needed where they were at. And so that was one of the early applications for telehealth. The encounter also had to be performed at a distance site where the provider, healthcare provider, was located, and that had to be defined by CMS as well. So originally, providers could not necessarily provide care, for example, from their home and have it reimbursed, because that wasn't an acceptable distance site according to CMS pre-COVID. Of course, the patient had to be present and involved in interactive real-time audio and video. And then the exact type of service had to be specified in the list of Medicare eligible services. So again, what this meant was most of the pre-COVID telehealth was provided to rural health clinics. FQHCs and RHCs at that time could not serve as distant sites for specialists. Telestroke was also a carve out for this. CMS actually removed geographical restrictions for the originating site for telestroke services in January 2019, largely because these decisions really needed to be made, whether to give someone clot busting medication, stroke management, etc. And there was a real shortage of neurologists to be able to provide that service. And so they removed, whether that was in a rural or metropolitan area, so they removed the geographic restriction for the originating site. There was limited coverage for e-visits, which are a type of asynchronous type of visit, and virtual check-ins, short, 5-minute conversations with your patient. Many groups also embarked on self-pay initiatives or cash pay initiatives. It was before the pandemic, you might have seen the proliferation of telehealth apps such as MD Live or Teladoc, or any one of a number of commercial apps that charge the cash price for their video visit services. And then many internally insured programs. Here at Loma Linda, our risk management department, which self-insures our employees, was an early adopter of telehealth and really wanted to see it grow and supported it very much from the beginning in order to provide increased access to their patients. And so a lot of telehealth programs started with those type of self-insured programs at different institutions around the country. And then with regards to commercial insurance policies, there were a lot of scattered policies depending on the payer. One strategy that an academic institution used was they weren't even sure if commercial entities would reimburse for telehealth services or not, but they would go ahead and provide it and then bill the insurance and see if they got reimbursed. And oftentimes they actually did. So this is a timeline to go over the telehealth journey here at Loma Linda. So back in 2015, senior leadership, organizational leadership had identified telehealth as a strategic growth area. So at the time, myself, Padmini Davimoni, and Trevor Wright were appointed as telehealth leads for Loma Linda. In 2016, we began sort of the legal compliance and LEAP infrastructure work in partnership with our information services department, who had always wanted to embark on this journey and had set aside funds to do so. And we actually implemented e-visits, so asynchronous visits in family medicine, general internal medicine, and pediatrics. In 2017, there was continued development and growth of telehealth. We were really trying to grow even without all the reimbursements set in place, knowing that this would be an important way of delivering healthcare in the years to come. And we started to implement video visits in family medicine at that time. And when I say implement video visits in 2017, I literally mean I had a few slots on my schedule and allowed patients to schedule video visits so I could see them. In 2018, we moved on to e-consults being implemented in dermatology. Dermatology has a long history of using asynchronous store and forward to provide dermatologic care to places who didn't have access to dermatologists. We also expanded video visits in neurosurgery. Dr. Bowling, the chair of neurosurgery here, identified telehealth as a technology he wanted to see used more and more to provide post-operative care and increased efficiency in surgical patients. And I should have highlighted it more, but one of the greatest things that we did here at Loma Linda is we actually decided to hire a dedicated telehealth program manager, Yamilet Medrano, to grow the telehealth program here. And she's really been instrumental in meeting with groups and helping people work through workflows and getting to all the projects that we had and getting them to completion and working closely with IS and with the operations. And so having a dedicated telehealth person was really crucial for us here at Loma Linda in growing the telehealth program. In 2019, we continued to expand video visits to the Center for Health Promotions, to general surgery, psychiatry, neurology, all the primary care clinics, as well as general pediatrics. And we expanded e-consults to our hematology colleagues who felt like they could answer a lot of simple questions through e-consult and help triage patients. And then in 2019, we developed a digital health work group to sort of look at not just telehealth, but all of our digital health workflows here at LUH to try to streamline the process and bring technologies and efficiencies in how we delivered care in an organized fashion. And then, of course, 2020 came, and video visits were expanded to all physicians and hospital clinics amid the COVID-19 pandemic. And then we've continued to expand e-visits and e-consults to more and more departments. So this is just a brief timeline in regards to what we've done here at Loma Linda. So in 2020, picking up from that last slide, some of the things that made the widespread adoption of telehealth possible during the COVID-19 pandemic were essentially the public health emergency waivers. So these are Waiver 1135, which really allowed us to provide telehealth in a very general fashion, sort of outside those 5 preconditions that I mentioned previously. So with the waivers, there were no geographic restrictions for patients or providers. All healthcare providers were eligible to bill Medicare, could bill for telehealth services, including FQHCs and RHCs. There was expanding coverage for telephonic or telephone encounters where video was not available. There were some very important state licensing flexibilities that were pushed out. Now, I mentioned here that there is a caveat because, of course, the practice of medicine is regulated by each state. And so oftentimes, even if by CMS's definition, you could go and provide healthcare to a patient located in a different state, you wanted to make sure that you were still following state-by-state guidelines. And so many states actually issued waivers and did allow you to practice medicine in their state, or had a process set up where you could get emergency privileges in that state. However, a lot of those flexibilities have already expired. And so it's important that if you choose to pursue providing telehealth in a different state, that you work closely with your legal and compliance people to make sure that you're providing in a way that is compliant and follows the state-by-state rules. And of course, one of the most important things that occurred was that HHS actually suspended HIPAA enforcement in terms of what telehealth software or video platform you could use. So realizing that many practices would not have had the opportunity to sign business associate agreements with vendors, they essentially said you can use any video technology that's not public facing in good faith, and that even without a BAA, HHS would allow you to use that video technology, such as FaceTime or Google Meetup or any type of technology like that, to provide telehealth or video visit care. And they would not enforce HIPAA for use of that in good faith. Now, that's not, of course, free license to use whatever software you want indefinitely. But during the pandemic, it did give a lot of flexibility at the start so that providers could provide video visit care and provide it quickly and safely. So I've been mentioning the COVID-19 pandemic quite a bit. And so here at Loma Linda, here is a timeline of COVID-19 and telehealth. And so it was actually back, in January was when the WHO had sort of announced this mysterious coronavirus-related pneumonia. And around that time, January 21st, we saw the first U.S. coronavirus case in Washington State. This was, and sort of, if you look at this graph, you'll also see the weekly volume of telehealth visits that we had here at Loma Linda. And so you can see prior to March 15th, the California stay-at-home orders, we were doing, maybe anywhere from 30 to 120 sort of video, e-visit, e-consult type visits. And so it was around the end of February that the digital health team met and worked with information systems and said, we need to be ready in case something like this, the pandemic explodes, or the COVID-19 explodes and turns into a pandemic. And we need to be ready in case we need to provide remote care or video visit care at large scale. So plans were already underway to expand that capability. Then March 11th, Dr. Hilliard, the chief of cardiology and the chief operating officer of LU, the faculty group, had launched the COVID work group to look at workflows and emergency planning. And then I remember the weekend of March 15th was essentially when decisions were made that we would suspend elective surgeries, and that most in-person care would also be suspended, and that we would convert clinics to telehealth, whether that be telephone care or video visit care. And so that weekend was a very, very busy and crazy time to get things ready to make that happen. There was a lot of quick training and work late into the night by everyone involved, the operations teams, the clinics, the information systems teams, to build all of these things rapidly, to work with our access center. And so, and then you can see sort of the timeline, and that's when our telehealth visits really exploded. And so since then, we've continued to experience a lot of telehealth visits, even when you can look, if you look on the chart, March, I apologize it's so small, but March 3rd there, California actually lifted its partial stay-at-home order. And even though we did see a dip in the telehealth visit volume, it actually still stayed very strong, even when the COVID-19 pandemic was not surging. And so just to illustrate that a little bit more, here is a graph to look at sort of our telehealth visits. And I apologize, it's a little bit confusing just the way that this graph is made, but I just wanted to illustrate that the percentage of video visits or telehealth visits, including e-visits, phone visits, and video visits, has remained quite high. It's been anywhere from 30 to 70% of our volume, and even when the pandemic was not as bad here in California, our telehealth visit volume still remained quite significant, well over 35%. So I just wanted to bring that to your attention. So there's demand for telehealth visits. Some patients were probably still wary of coming in person, but I think there was also an understanding that many patients had their first visit and actually decided that this was an acceptable and maybe even a preferable way of of performing some of their health visits. And we've also had great provider or clinician adoption of telehealth. I had before the pandemic, we were sort of going clinic to clinic, sort of asking, are you interested, sort of peddling our wares. And afterwards, when the pandemic hit, clinicians were very enthusiastic because they understood that this was the way they could continue to provide care to patients. And I've had several providers after a few weeks of this tell me, can I just do telehealth? Can I not see people in person and just provide telehealth? Of course, we said no. We're going to provide care for patients in multiple different ways. So I think one of the important things for us to look at is patient satisfaction. So have patients been satisfied with their telehealth visits? Now we know that patient satisfaction, the sort of complexity around whether it's good care, but I do think it's an important metric for us to look at. And here at Loma Linda, I think we've been doing a good job with our telephone and video visits. You can see the percentages there for comfort with interacting, with the quality of the video and the method of connection. Now, you can see sort of the goals, which are based on averages around the country and for our region. And even though we're sitting around, we're well above the goals, the averages, you can see that the numbers are still fairly low. Only about 3 out of 4 patients are satisfied or feel good about their connection quality or the ease of the use. So even though we may be doing better than our peers, there's still a lot of work to be done in terms of making sure that patients are really getting a great experience when they have telehealth visits, and that they're comfortable, that the quality is good, and that the connection method is simple. So the current state, and I'm sure this is what many of you are dealing with in your own practices, doing telehealth, there was a mass proliferation of iPads and tablets through all the clinics. Some places installed second monitors, and there have been a lot of issues around camera and microphone quality. We've worked with spotty internet connections, sometimes variable by location, Wi-Fi connection speeds. There's been suboptimal software integration. Are we hosting the video on our servers? Are they being hosted in the cloud? And the issues surrounding that. And then I'm sure many of you have experienced, is the video visit appropriate? Should they have come in person? Was this a useful time for both the clinician and for the patient? And how can we maximize that? So I think there's still a lot of work that needs to be done in addressing all of these issues, because we sort of used telehealth during the pandemic in a blunt way, sort of a blunt instrument to provide telehealth care and to do it in the best way we could in the shortest amount of time possible. But I do think there's a lot of work that we can do to improve and refine the experience. And I'm going to talk a little bit more about that in a few slides, but there's a lot of work that could be done, because I think our current state, although it might be adequate, is really not maximized for all the parties involved. So I did mention that I would talk a little bit about pros and cons about telehealth. I mean, these are obvious, and maybe some not so obvious. But I'd say one of the pros is access, right? And this is it's actually a con as well. But there are some patients who feel more comfortable interacting this way. They feel very comfortable doing a video visit or doing a telephone visit. There's not the travel that's involved. There is more convenience. Obviously during the pandemic, when we limited in-person care, it provided a method of being able to see the patient and provide that care. Many of you, I don't know if maybe you could see this as a pro or con, but a lot of my older patients were very comfortable talking on the phone. These days everybody just sends a bunch of text messages back and forth, but a lot of my senior patients love to talk on the phone, and they're a little bit lonely, so they enjoyed sort of conversations to talk not just about their health, but about what's going on in their lives. I do bring up, I think telehealth also gives you an opportunity to see the patients in their home, right? To see their environment that they live, If there's a pediatric patient that is experiencing, I don't know, worsening allergies, what sort of home environment are they in? Where are they sleeping? If you have a senior who's falling often, what is their home like? Short of doing a home health assessment, look to see, are there carpets, are there rugs, are there things that they can trip over? It gives you an opportunity to see a patient in their home setting. And I think there's value in that a lot of physicians who have done home visits or do home visits, they get to see that, and it's helpful. And we can use telehealth in the same way. It's almost sort of a return to the home doc and being able to look into their house. And the example story I give for this is I have a patient who has really severe, almost debilitating anxiety. And for her to see me in clinic is very difficult for her. And I can tell that she's just very, very anxious. And, I do need to see her to discuss her medications in person and to see how she's doing. And every time she comes see me, it's this huge, difficult ordeal. And then I did a video visit with her, and I was able to speak with her, and it was really shocking. And I even commented to her, Miss So-and-so, you look so different in your home. You're much more calm. And she told me, yeah, this is how I normally am at home. And this is, I do feel much more comfortable here. And I was able to sort of see that and be able to understand some of the anxieties that my patient goes through when they're out of that environment. So I think for all those reasons, specialty access, there are a lot of advantages for telehealth. Telehealth offers. Now, of course, there are cons, right? There is, of course, the digital divide. Even though there is a proliferation of smartphones and faster internet speeds or Wi-Fi or wireless speeds, a lot of people do not have good access to broadband. There's still areas where it's not available. And I think that's becoming more and more apparent during this pandemic, looking at different areas. I'd also say sometimes it's very difficult to develop good connection with your patients. Things may feel very impersonal. Maybe it's easier for me with the patients that I know and have a relationship with to do a video visit, but ones that are new, it's hard to really get a sense of who they are and sort of what their needs are, and to have that human and personal connection through video to the same extent as you would in person. And I do think there are limitations of the physical exam. There's a lot of literature right now looking at the physical exam, and we all know that our physical exam skills are maybe not as good as some of the physicians who've taught us. But there's still value in history-directed physical exam that either confirms or doesn't sort of the differential diagnosis that you have. So how can we use technology to sort of mitigate some of that loss of physical exam? Or are we training people to think about how to do a proper physical exam through telehealth? So as we think about the pros and cons of telehealth, I would like to sort of transition to think a little bit about the future state. So we know that this pandemic has led to really widespread adoption of telehealth as a temporary replacement for in-person care. Now, the problem with that is that, like I said, it was done in many ways. It was done very rapidly with maybe suboptimal technology or infrastructure in place. And so, for some places that may view it as just a temporary hold thing that we're doing until we can get back to business as normal, I don't know if that's really going to be the case. And I think along with that is understanding this rise of consumerism and digital health. So you now have millennials, both as patients and as clinicians, who have a relationship with technology and with with texting, with FaceTime, with video, with much faster internet connections. They have a relationship with technology that is very different than even someone from my generation. And so, how are you going to understand that better and being able to meet patients' needs? Like I showed on a previous slide, even when the pandemic wasn't that widespread, when it had sort of calmed down quite a bit and our hospital volumes were less, we still saw a large percentage of patients elect to get their care by telehealth. And so I do think we're going to see some patients continue to use this this mode of providing healthcare to get their healthcare, and we're going to have to figure out a way to do this and to do this well going forward, because patients are going to sort of demand it and look for it from their groups, because they've experienced it and they've experienced the pros, and for many of them that outweighs the cons. Of course, it's important to always note that technology itself is never the solution, right? Having the very best telehealth suite and the very best cameras and microphones do not replace having a good workflow and having good nursing support or scheduling process in place. The technology itself will not solve all of your operational things that you need to figure out. You know, it's there to be used to sort of help you take your workflows to the next step and to improve efficiencies and provide some new and exciting, innovative ways, but you really have to have the workflows worked out. You know, here at Loma Linda, I'll just give an example. We had tried to do some work with remote patient monitoring a few years ago, and I'd say one of the lessons we learned was the technology was there. It was good. It was not perfect, but we did engage with a vendor who had good technology. But I'd say operationally, we weren't really ready. We didn't have all the operational workflows down. And so that particular pilot really didn't flourish because we tried to sort of push the technology before really having the workflow down. So I would encourage you, before going and interfacing with a vendor or a solution, is to first sit down and think, what processes can I achieve using the technology that I have currently? And how do we do this in an analog way well, and then look towards digitizing it or finding efficiencies in using a better tool, rather than thinking that the tool itself will bring you the workflow or the solution. Telehealth is really sort of just a tool, right? It's not the solution in and of itself, but it is a tool that can either be used, like I mentioned before, as a blunt instrument, or it can be a scalpel in the hands of a skilled plastic surgeon, or it can be like a blunt instrument in my hands. So in terms of the future state, what I would like to get everybody thinking about, I think we're going to see more and more proliferation of devices, right? So this is remote patient monitoring devices as the technology matures. Everybody bought a pulse ox during the pandemic. A lot of my patients were monitoring their COVID symptoms at home. There is an explosion of health-related apps, whether those are mental health apps or behavioral modification apps or monitoring apps that will interface with your health record. There are government regulations in place now that require you to share your health record with whatever health apps are out there. And so there's really going to be an explosion, I think, of devices and using devices, and a lot of big studies that are coming out right now that are currently underway that will look at things like Apple Watch for diagnosing things like COVID. There's already a big study going on with atrial fibrillation with Apple Watches. And so I think we're going to see a much bigger proliferation of devices and home monitoring that we haven't seen before. I think one of the other areas that is under development is medical student education. So we need to teach it, and we need to teach students how to do it and how to do it well, and how to have good website banner, how to develop their physical exam skills, how to make sure they're documenting properly when they perform a telehealth visit, talking about anticipatory guidance, or when they're giving advice, understanding how to triage patients, right? When they see them by video, when is it okay to do a video visit? When is it not? Or when do you tell them, I need to see you in person, I need to lay hands on you, or when do you need to go to the urgent care or the emergency department? So the AAMC has actually put out sort of draft recommendations for milestones, and that they want to see both medical students and residents reach as they work towards becoming future physicians doing telehealth. And that's work that we're undergoing here at Loma Linda as well, working with the School of Medicine in the preclinical years and in the clinical years. We're playing a little bit of catch up because the telehealth explosion happened for a lot of third and fourth year students who had no exposure at all. So we're trying to educate students even earlier in their first and second years to think about telehealth, to think about technology, to think about how I really believe that this younger generation of physicians and students are the ones who are going to come up with the innovative ideas and the exciting ideas of how to use technology and how to help patients with it, because they just have this different relationship with technology. And then I think for those of us that are already in practice, I think there is going to be a lot of continuing medical education with how we can provide better telehealth. So how to improve the patient experience. How do we improve the richness and the appropriateness of the data that we might get, and how to use it and interpret it? When do we use certain modalities for patients? There are very innovative products that are out in the market right now. Home stethoscopes or digital, being able to look at tympanic membranes and throats and listen to lung sounds and integrate with blood pressure cuffs and what to do with that data and how to adjust, how to not just telephonically monitor your heart failure patients, but how to get that information remotely, and how to use AI then to sort of analyze that data as far as when to trigger an alert to the clinician or to the care team and back to the patient about when they need to increase their Lasix. There's just a lot more that needs to be developed and is currently being developed. And then how do we maximize the use of limited resources? And I think the reality is that there are fewer and fewer specialists to be able to provide care for patients, and oftentimes. So how do we use telehealth to mitigate some of that? How do we use e-consult so that the specialists can handle sort of the simple issues and then triage the ones that they really need to see? And I think as a primary care clinician, as I use more and more e-consult, I think I'll understand better. Oh, these things I can handle on my own. These things, really need to be sent, and try to be a better steward of limited resources. And I'll just briefly say, when we think about future state, we do have to bring up this consumerism, right? And so it's very important that we need to focus on the patient experience, right? Brand loyalty is really not what it used to be, no matter how good it is. There are several examples that I'm sure you could think of. In the past, you may have been a club member, or maybe if you fly a specific airline. Some people are just fiercely loyal to Southwest or to a particular airline, and that's all they fly. But many consumers will go on websites and try to find the cheapest price, and who can provide their needs and meet their needs as quickly as possible. And so I think it's very important that we do work on the patient experience and make sure that when they interact with our organization or with your practice through telehealth, that they have an excellent experience. For the clinicians, I think it's important to focus on our experience, right? How do we maximize the audio and video quality? How can we speed up the user interface or make it more smooth and seamless, and not have to worry about clicking this or touching this? And then I always mention workflow. How do we improve the workflow for telehealth and make it as efficient as possible? Right now we're sort of mimicking in person, which is good. But I think the next step is to say, okay, there are things that we need to do, quality metrics, things we need to do, even with the video visit. But how do we really customize the visit to make it more efficient? This type of video visit doesn't have to be 20 minutes. It can be 10 minutes. Maybe I can see another patient. So I'm trying to understand how we can maximize telehealth workflows that we have. I think along with that is deciding which visit types work best as a video visit, and then incorporating and expanding our tools to make the telehealth visits more smooth. And then I do think we do need to take, again, a hard look at remote patient monitoring and mobile health. So here is a slide. Any of the slides that you see that are not sort of basic text were prepared by Yamilet Medrano, our program director now for digital health. And I think this is just a sort of graphic to help visualize a lot of the different endeavors that we're working on, right? So how do we improve self-scheduling? How do we use artificial intelligence and a chatbot to help patients schedule and find clinicians and find clinics with openings and answer questions and try to decrease phone utilization for our access center? How do we automate our referrals and make sure that as much as can be automated is, so many of our processes are still very manual and they don't need to be. How do we remind patients at certain intervals, not in an annoying way, but in a way that sort of partners with them? How do we continue to improve video visits and the experience, remote patient monitoring, virtual rounding in the hospital? We've seen the necessity for that with COVID-19. How do we continue to expand on home diagnostics and do even group visits, right? Expanding our video visit technology so that we have some clinics here and some specialties that may have at one time 15 providers with one patient. Some of our specialty neurology clinics. And so how do we make sure that our technology can support those workflows and the patients have a good experience? So before we move into the Q&A time, I just wanted to share two quick stories about how I really saw telehealth benefit both me and my patients. Now, I know many of us can think of stories when the video technology failed or the connection was poor, and it's trying to helping a senior, helping my dad with his computer. It can be one of the most frustrating things. But these are two stories that I'll not forget, and I think telehealth really helped provide better care for them. So the first is a gentleman. He was a partner of one of my patients, and he essentially had not been feeling well for the past few weeks, and he was nauseous, was having recurrent low-grade fevers. Maybe a mild cough. And he actually had gone to the urgent care and emergency department even on several occasions. And he was told several times that he did not have COVID-19 and was sent home. And so when he saw me and he looked, being able to lay eyes on him, he had a sort of desperate look in his eye. And I was a little worried. And he said, Doc, something's really wrong. And so after speaking with him and reviewing his chart and actually hearing that he had been seen in person on several occasions and had blood drawn, it kind of forced me to think outside the box. And so I looked and I noticed, hey, this gentleman had surgery about a month ago. And it sort of expanded my differential. And I was able to order some tests for him and essentially determined that he was actually bacteremic and he had had a complication from the surgery. And so I really feel like being able to have that telehealth visit and be forced to not depend on, tests, but just really, really listen. Knowing that he had already been seen in person, I think really helped me get to the bottom of what was going on with him. And so he was able to get admitted and get treated. The second story I like to tell is I had a gentleman, he was another patient of a partner who came in and actually by video and had a complaint about I think it was URI symptoms, and it was something that was pretty minor and pretty easily addressed by telehealth. But I happened to peruse his chart as I was speaking with him, and I saw that he had a positive fecal cold blood test about over a year ago, and that even though a colonoscopy had been ordered by his primary care clinician, he had never had that done. So I had the opportunity to say, Mr. So-and-so, we've taken care of the other issue, but this is what is important to me. As I see that you haven't had this done yet, we want to make sure that you don't have colon cancer. And so I was able to, by telehealth, order that colonoscopy for him. And lo and behold, he actually had a colon cancer that was found in colonoscopy. And, this is a gentleman who lived quite far away up the mountain. And that was probably one of the main barriers for him coming in the clinic and maybe having this readdressed. And so telehealth really enabled me to be able to have that connection and have that access with that patient and have him get that colon cancer diagnosed and get him over to the surgical oncologist and have it treated. So, I think telehealth, has so much potential and is an area that will really explode as we move forward, even more, kind of moving past the pandemic and looking at how can we, now that it's sort of gained widespread acceptance, how can we now refine it and improve it and use it more discerningly and to improve the experience for both clinicians and patients. So that's all that I have. Thank you very much. Here's some references for some of the historical information that I shared. And in a little bit here, I'll be happy to take any questions. Thank you very much. It's been a privilege to spend this time with you here at APC. Thank you.
Thank you so much, Jeff. I just want to say that I'm really glad that your wife still married you despite your wielding that, large Dell phone all those years ago. So good job. She must have seen past the phone and saw the true Jeff. So a couple of questions here. I know that for years that you personally have been trying to promote telehealth, for the delivery of medical care, and there was a fair amount of resistance to adopt by providers. And it really, and that graph that you showed is excellent. I mean, it took an absolute necessity with the pandemic to really drive and achieve essentially universal adoption in all the departments here at Loma Linda. So there also had originally been some resistance from the patient side to participate in telehealth, and certainly that has changed. Thinking about, you mentioned all these things, access and convenience for the patients. How have you seen these changes, and where do you think we're going to settle into this telehealth thing, say a year from now, 2 years from now? What are your thoughts on that?
Yeah, thanks, Dan. I think, it was hard, but I think in healthcare, change is slow. I think that's just the reality of and sometimes for very good reasons, change is slow. But I think in about a year, you're going to see, just like we showed on the graph, I think there's still going to be a large subset of patients who are going to embrace telehealth, whether for necessity or convenience, and they're going to want that modality, and they're going to want it to be done not just in the blunt way that we do it now, but in a much more nuanced and focused way. And so I think it's important that we sort of pivot and be able to provide that sort of experience for patients. Otherwise, they may, I think the older generation of patients, a lot of them are very loyal. They're going to stick with us. But that younger sort of consumerism-driven generation, they might look elsewhere. They're very review-driven. It modifies their behavior. And so I think it's going to be important that we really focus on the patient experience as we go forward.
Absolutely. How do you see, so specialty care? There are a lot of places in the country, and certainly even in our state, very remote, rural areas, hard to get down from the mountains when the weather is bad, that sort of thing, and certainly limits access to care, maybe access to primary care, but especially access to specialty care. How do you see this, and particularly in our institution, in the specialty, from the specialty side, how is the use of telehealth going to really help us with access to that kind of care?
Yeah, I think that's a huge struggle for institutions around the country when we talk about telehealth and access to specialists. I think e-consult is very exciting. I know you have used it. I've used it for dermatology, for endocrinology, for hematology. And I think what it does, it actually improves response time. And we actually learn when we do these, meaning when I do an e-consult to a hematologist for the same thing 2 or 3 times, I can quickly recognize, hey, I should probably be doing this and this first. And I think what telehealth is going to force us to do is to collaborate even more with our specialists. It sounds silly, but in the old days, you would pick up the phone and you would call your cardiologist friend if you had a question, instead of just putting in the referral and sort of hoping that in the nebula of referrals, it gets processed. I think hopefully telehealth will provide that technological sort of highway straight to the specialist, where we could do an e-consult or future state have a real-time video visit. How amazing would it be if I saw a patient that I felt like needed to see a cardiologist or a surgeon. And then I could quickly contact one of my colleagues by televisit, and we could have a quick, three-way televisit. And that could quickly establish with the specialist and get the care that they need, instantly. I mean, I think the patient satisfaction will be through the roof. So I think we need to really look at how we can use the technology with very limited resources going forward.
Yeah, excellent answer. So you had some comments about this earlier, but the idea of interstate care. I know there's some regulations right now, licensing regulations and so forth, but where do you see that headed in the future?
Yeah, I think there's a lot of conversation going on right now about sort of state licensing. You license in one state and therefore are licensed in other states. I think until that happens in a widespread way, we're going to be sort of stuck in the current state that we're in. Again, even with the waivers and even with CMS's directives, the landscape for interstate care without a blanket policy is going to be very, very tricky. And so I think we're going to move that way. I mean, large organizations that do telehealth for a subset of states, they actually license all their doctors in those states. So they sort of eliminate the barrier. If you're a referral center and you see patients in your 5 closest states, well, the doctors that are providing telehealth are going to get licensed in all those states so that there are no issues. So I do think we are going to move in that direction, and there's a lot of movement right now to have that sort of interstate licensing, and hopefully that's where we'll land soon.
Thank you. So one last question. You mentioned that one of the barriers of telehealth is the lack of the physical exam, and yet you mentioned several things. I mean, vitals. You can have someone check their blood pressure, check a pulse ox, a pulse, a weight. Those types of things. What do you think the next steps are in terms of the physical exam, the objective element of our evaluation? Where are we going to head next with that?
Yeah, I think some of it is going to be very simple, meaning, if you see a telehealth visit and it's for a musculoskeletal exam, you should probably prep the patient ahead of time. Wear a tank top so I can see your shoulder, or, be in a well-lighted area and make sure that you're not driving, have that sort of directive for that particular visit. I mean, simple things, and then teach our students and residents to be able to examine, to not just look at them, but to say, hey, can you do these motions? Can you mimic some of the physical exam skills, and so that I can see where the deficit is. I think more than that, though, we're going to see more proliferation of devices. I mean, there are really amazing devices out there that you can go and buy at Best Buy, and you can actually capture the tympanic membrane. I mean, I think we've seen these, Dan. We've seen, you can listen to the heart sounds with amazing fidelity, and then also be able to harness that remote patient monitoring. If the patient has a pulse ox, we're able to see those numbers. I mean, that's incredible data, right? And I have patients who will sort of just type in their blood pressures, and I'll look at them. But to have that automated and to use AI to analyze that, to say, hey, these numbers are okay, but whoa, this is something we need to intervene on now, and be able to reach out proactively to patients, say, hey, for the most part, your pressures have been good, but this one was way out of whack, and we need to understand why that was, to try to prevent something really bad from happening. I think we're going to see that, and we have to embrace it, because it's definitely out there, it's coming, and there's just it's sort of endless, the technologies and the apps that are being developed and are out there right now.
Well, thank you so much, Jeff. We really appreciate your time and bringing this information to us. We know that we're going to be hearing a lot more, learning a lot more, developing a lot more, and I just want to tell you thank you for your service to this institution in our community. It's made a big difference in our community, and without it, we wouldn't have been able to manage this pandemic. So thank you very much, and thank you for those very wise words.
It's been a privilege to be here and to do this work here. So thank you.
Thanks.